Oded 他的研究重点呢是探究人类工作记忆和执行功能的脑机制，也希望能够开发功能性的神经标记物和非侵入式的神经调控干预措施，来改善神经精神疾病患者的认知功能。那么像另外一个报告的这个联合的作者呢是里奥Mocho 教授，他是一个也是来自以色列的一个他是 NeuroSteer 公司的临床试验经理。那么这个公司呢是同时在以色列和美国有工作，主要研究方向是考察工作记忆、执行功能和情绪调节这些认知功能的脑活动模式，也特别关注功能退化和认知衰退，并且利用单通道的脑电设备呢开发功能性的生物标志物。他们两个人报告的，我们看他是两个人是谁来报告啊？他们报告题目也是集中在这个经颅直流电刺激方面的。他们题目呢是把向前额叶的经颅直流电刺激结合单通道的 EEG 监控系统这样一个这个治疗系统的一个研究。欢迎他们的报告。
Hello, everyone. My name is Oded Meiron. I'm one of the researchers from Herzog Medical Center in Jerusalem, Israel, collaborating with NeuroSteer research team, and will present research on EEG reactivity changes following TDCS intervention. And these are actually initial pilot results in disorders of consciousness patients. Basically, we want to examine a new intervention in disorders of consciousness patients and monitor brain activity changes and clinical status. So this is really the main purpose of the study, as I said before, and I will rephrase it in this particular slide. We're going to apply 10 days of transcranial direct current stimulation in hopefully up to 20 disorders of consciousness patients. In the current presentation, we'll present only 5 patients' results because the study is still ongoing. We're interested in brain activity and in clinical status before and after TDCS intervention, and we will follow the patients 3 months follow-up, 6 months follow-up, and also 1 year follow-up measurements. All right, so transcranial direct current stimulation is considered a safe neuromodulation technique, non-invasive neuromodulation technique. It actually modifies the neural excitability into a certain direction towards depolarization or towards hyperpolarization. It does not stimulate immediate action potentials like we do with TMS, or does not inhibit immediate action potentials like we do in TMS. It's a much more gentle form. That's why of stimulation. That's why it's called neuromodulation. As you can see, the protocol of the study is listed here in this slide, 20 minutes a day, across 10 consecutive days, with coma recovery scale scores examined before and after the treatment. All right, one of the main brain activity measures, which is actually a functional brain activity measure that we're going to collect, is called mismatch negativity. It's a type of auditory evoked potentials that actually can tell us if a person can hear a certain sound pre-attentively in the first 100 milliseconds from tone onset, and whether the patient or the participant can detect change in the acoustic environment. So as you can see, there's a standard tone that repeats itself and an unfrequent odd tone or deviant tone that repeats itself only 10% of the time versus 70% time of the standard. And what happens is when deviant sound or an odd sound, which is very close to an oddball paradigm, an odd sound appears, we're supposed to see a larger negative deflection at around 100 milliseconds. As you can see at the bottom right, we can see actually the difference between the standard waveform and the deviant waveform, which is usually supposed to be a very strong negative difference, as we can see in the bottom in a healthy subject. And we hope to modify the difference between standard and odd sounds by using the novel transcranial direct current stimulation, hopefully also affecting their clinical status. So the research paradigm, as we said, we're going to excite certain areas in the brain towards depolarization. Actually, we're going to excite the left dorsolateral prefrontal cortex, which is the target area. The reference electrode, which is the cathode electrode, is placed on the right supraorbital area. We're examining auditory evoked potentials, which are also called mismatch negativity event-related potentials, at baseline and at post-treatment. And also, we examine their clinical status at 1 month, 3 months, and 1 year after treatment. The paradigm is listed at this slide. As you can see, 10 days at the bottom. And at pre, we examine 32-channel EEG system, a clinical grade system. And also, we're using the single-channel system by NeuroSteer, which divides the electrical signal into 120 different components, later using them as biomarkers of certain neural circuits and certain activities and behaviors associated with these particular brain patterns and different changes in biomarkers composed by the single channel system of NeuroSteer. Of course, they have an algorithm which they developed, which actually divides this particular signal into 120 different components. So as we can see, the main findings in relevance to mismatch negativity event-related potentials, we see that the negativity actually changes only in 3 particular patients, P12, P13, and P14. As you can see at the top left, these patients are the etiological background, clinical background is either a CVA, anoxic brain damage, traumatic brain injury. As you can see, P12 actually shows the most interesting positive pattern following treatment. We can see that in the center frontal areas, we can see significant negativity, which is actually the difference between the standard negativity, or actually the odd negativity, minus the standard negativity. We see also a nice change in central frontal, a bit shifted to the right, but still a significant change in frontal central negativity in P13. And we see a very small change in P14 negativity in frontal parietal areas. And these findings were also correlated with their clinical status and with NeuroSteer biomarkers. So this actually summarizes the improvement that I just described. So the change detection of an odd sound versus a standard sound is possibly being transmitted to consciousness at least partially or part of the time, most possibly in P12 and in P13. It's also slightly registered in P14, so we can hypothesize that these 3 participants are possibly aware of the change in their acoustic environment, and P11 and P15 are possibly not aware of the change in their acoustic environment, and that's why we don't see also a significant change between the odd sound waveform and the standard sound waveform. So this part of the presentation that I was responsible for, I'm going to sum up and move forward towards the next part of the presentation, which is going to talk about the NeuroSteer EEG biomarkers in relevance to these particular patients before and after TDCS intervention. Appreciate your attention and have a good presentation.
Hi, my name is Lior. I'm a neuroscientist and work in NeuroSteer. In this study, we used NeuroSteer Aurora, an easy-to-use single electrode EEG system. a 3-electrode patch is placed on the subject's forehead for a quick and simple setup. An automatic test correlates brain response with a set of auditory stimuli for a detailed brain response analysis. We use novel signal processing algorithms based on advanced wavelet packet decomposition, as well as machine learning tools for signal analysis. In previous work, we examined healthy participants and found biomarkers for different cognitive stages, stress, and emotional regulation. Specifically, I'll talk about the VC9 biomarker. VC9 was validated on data of healthy participants performing the NBAG task with a few difficulty levels in which the cognitive load was varied from low to extremely high according to the level difficulty. The results show that VC9 biomarker is indicative of working memory load or cognitive load levels. It was also found that in comparison to frontal theta, the VC9 biomarker was more sensitive, showing more subtle variations in working memory load between the lower level of the NBAG task. The same biomarker was validated in several other trials with healthy participants and showed correlation to cognitive load. Then, we examined the VC9 biomarker in cognitive decline patients performing auditory cognitive battery, which can be automatically administered from our monitor. VC9 biomarkers show different activity patterns for the clinical patients with cognitive decline compared to the healthy participants. In this study, we looked for differences in VC9 activity between pre and post TDCS treatment for each patient. Results show that in most patients, VC9 activity increased after the stimulation. An increase in VC9 is associated with higher cognitive functionality. The analysis shows highly significant changes for P12 and P14, and lower changes for P13 and P11. P15 shows opposite results, with activity decreasing after the treatment. We also calculated the frontal theta power measured in frontal electrodes by Neurosphere. Recent studies show that theta power in frontal regions increased after TDCS treatment in disorder of consciousness patients. Looking at the frontal theta, we see that activity increased for most patients with significant changes. P12 stands out here again with the most significant change. It should be noted the study suggests that increase in theta power following active TDCS may reflect a higher level of conscious brain activity, even if it is not translated into behavioral responsiveness. P15 shows high significance in the opposite direction with decrease in the theta power after the treatment. This table summarizes the initial results of this pilot study, presenting 4 parameters measured before and after TDCS treatment in the 5DOC patients. The first column presents the p-values between odd and standard tones in the mismatch negativity as captured after the treatment. The second column presents the p-values between mean activity of VC9 for pre versus post-treatment. The third column presents the p-value between mean theta activity as measured by Neurosphere for pre versus post-treatment. The number in the parentheses presents the prime parameter, which indicates the effect size. The fourth column presents the changes in Coma Recovery Scale Revised, or CRSR scores, between pre and post TDCS. We can see that in all of the parameters, P12 showed significant changes, with increased difference in MMN results indicating a more negative and frontal activation, increased activity of VC9 that was found in previous studies to indicate higher cognitive load levels, increased theta power that was indicated to relate to cognitive improvement after TDCS, and even an increase in Coma Recovery Scale results. This is in line with a recent publication showing this patient's improvement in discrimination accuracy in clinical measures. Further, we see that VC9 activity highly corresponded to mismatch negativity results with an increase in patients 12 to 14 and no increase in patients 11 and 15. Frontal theta power shows correlation to Coma Recovery Scale results, which are less indicative, seeing that it is a clinical behavioral change that needs to be noted by the doctor rather than an objective measure of spontaneous response like the mismatch negativity. P15 shows an opposite effect to all the other patients. a decrease in mean activity of VC9 and frontal theta. Taken together, the results of this patient point to the opposite direction than P12. We have a theory regarding the decreased discrepancy in P15 and the rather small size effect of P13 surrounding the location and latency of the mismatch negativity, which require further investigation. Altogether, these initial results show objective neurological measurements for active TDCS effects in patients with disorder of consciousness. Some of these measures were collected with an easy-to-use single-channel EEG by Neurosteer, which can potentially provide a simple and automatic monitoring tool to assess patients' neurological status and progress, correlating with known objective measurements. The initial results in disorder of consciousness patients show EEG reactivity changes following TDCS intervention. Thank you very much for listening.
好的，我们也同样非常感谢来自这两位讲者给我们带来的精彩的报告。这是二重唱式的报告啊。开始我还没搞清楚到底是两位这个科学家谁来做报告，结果是这个男女生二重唱，每人负责了一部分。那么前面这一部分呢，主要是给大家介绍了这个失匹配复播在临床评估当中的应用价值。那么后面一部分呢，主要是一个这个临床转化的工作，也就是 Neurosteer 公司他们放到临床应用的一个这个可以通过3个贴片额叶贴片、脑电贴片单通道的这个脑电监测的便携式设备，可以给大家这个提供一个这个治疗前后脑电变化的特征分析，特别是提出一个 VC9 这样一个 biomarker， 可以在这个失匹配复播、德尔塔频带功率这些个临床效果的这个基础上，还可以增加一个分析的一个维度，就增加我们对治疗的效果的评判的一个客观性和可信度。这两个报告是非常这个让人感兴趣的报告。那么我们抓紧一点时间，我们进入到下面一个报告。下面一个报告呢，也是一个二重唱式的报告。那么第一位讲者呢，将是来自这个比利时安特卫普。那么这个安特卫普是这个钻石之都啊，这个全世界70%的钻石交易都是在安特卫普执行的。那么这个Edward 博士呢，他是来自安特卫普一家神经康复的诊所。这个康复诊所呢，他们的执行的主要的项目是 TrainM。TrainM 的这个联合创始人、首席执行官就是 Edward。那么 TrainM 他们主要的目的是治疗患有各种神经疾病的儿童和成人，比如说脑瘫、这个多发性硬化、帕金森、中风、脊髓损伤、TBI。那么TrainM 可以给病人提供个性化的高强度的机器人治疗，并且结合各种非侵入的技术，比如说神经调控啊、虚拟现实、神经游戏、人工智能、脑机接口，这些名词听起来都是非常时髦的啊，也是非常这个红的，可以说是很多网红的工作。我们听一听，等一下 Edward 的报告。那么下面报告的另外一部分呢，是来自这个也是 TrainM 的首席物理治疗师。那么首席物理治疗师比较擅长应用机器人技术辅助治疗，来提高神经系统疾病以及神经意识障碍患者的康复能力。当然也有另外一方面非常突出的特色，就是怎么样根据病人的情况制定个体化的治疗方案。刚才在我们听这个经颅直流电刺激的时候，其实比利时列日大学的他们昏迷科学的研究组也已经在他们的报告当中强调一个个体化的治疗方案。那么我们听听来自安特卫普大学安特卫普的这个康复机构，他们对个体化方案是怎么样一个推进的一个工作，相信会对大家有很多的参考价值。欢迎。
Hello, my name is Edward Schitikata. I'm co-founder and CEO of Trainem Neuro Rehab Clinic in Antwerp, Belgium. And today we will be talking about challenges of outpatient neuro rehabilitation in disorders of consciousness and our specific expertise from Trainem. Before we go into the more technical part of the presentation, I would like to say a few words about our center. So basically, Trainem was founded in 2017. We are an outpatient neuro rehab clinic in Antwerp, where we treat children and adults in the chronic phase. Typically, we sometimes have patients who are in the acute or subacute phase, but the majority of our patients are in the chronic phase. We do offer high intensity therapies where we basically focus on the neuroplasticity of the brain. And we do this with a team, a wonderful team of medical professionals. We have 10 neurophysical therapists on board, a neuropsychologist, a neurolinguist, and a neurologist. Trainem is a very technological center where we have robotics. We use VR, neurogaming, brain-computer interface, and also non-invasive neuromodulation to enhance the benefits of robotics, and we use either TDCS or RTMS. The indications we treat at Trainem are mainly neurological in nature. We treat patients with acquired and traumatic brain injury, locked-in syndrome, cerebral palsy, motor neuron diseases such as ALS, multiple sclerosis, muscular dystrophies, Parkinson's disease, spinal cord injury, and stroke. A minority of our patients come here with orthopedic issues or post-op problems such as paralysis or hand injuries, amputees, and also patients with hip replacement. But those are a minority of patients at Trainem. At Trainem, we have a multidisciplinary approach to wellness and recovery. It all starts with the community of patients that we've built over the past 5 years. We treat our patients with dignity and compassion. We do gather a lot of information and data about our patients. We do in-depth assessment with our team of the patient's situation and the recovery plan and the goals for recoveries. And we offer integrated therapies. Basically, at Trainem, we combine technologies, human intervention in a motivating environment. Patients at Trainem receive on average 1,000 movements per session, which is basically 20 times more than conventional therapy. What sets Trainem apart is that we achieve measurable recoveries. And basically, we start by setting very specific goals for our patients. Then we sense, which means that we use sensors to generate precise motor function data of our patients. We assess, so our medical staff assesses the data and plans patient-specific augmentation strategies thereafter, which is basically based on individually tailored protocols. And we also give accurate feedback after each session to our patients, which is also something that sets us apart. So we do analyze the data and give immediate feedback to our patients about their performance in a specific session. Trainem is basically designed to enhance motivation and well-being. We have a very beautiful space, approximately 10,000 square feet, that is filled with light and music, which also enhances the recoveries of our patients. The robotics we use for pediatrics and adults are threefold. So we do have an entire floor designed for gait training. So as you can see in the first row, we have a Geo walking robot for children and adults. We have 3 Locomats, 1 Locomat Pro for children and 2 Locomat Pros for adults, and also a Walker View. For arm and shoulder, we have the InMotion arm robot designed at MIT, We have Armio Power and 2 robots from Tyromotion, the Myro and Diego. For finger, hand, and arm, we use the Pablo and Amadeo, also from Tyromotion. We have also an entire floor dedicated to functional training for our patients, functional therapies, where we do balance trunk control training. What sets Trainum apart is also our group of scientific advisors who've been very involved with Trainum since the beginning, who've been big supporters of our initiative. First one is Bruce Volpe, who's been spending most of his career on rehabilitation and doing research on robotics and the combination of non-invasive neurostimulation and robotics. We also have 2 professors from Warwick Medical School, Damon Hoad and Professor Diane Playford, who is very much involved. Dylan Edwards, who's a director at Moss Rehabilitation Research Institute, professor at Weill Cornell, and also a co-director of a course on transcranial magnetic stimulation at Harvard Medical School. Gary Colombo, who is the founder and former CEO and chairman of Hokoma, and Professor Krebs, who is the inventor of the InMotion arm robot, who is a researcher at MIT. We also have a number of scientific advisors from Belgium. Dr. Dekkers, who is a former head of physical medicine and rehabilitation at GZD Hospitals in Antwerp. Dr. Tony van Havenberg, who is the head of the neurosurgery department at GZD, but also the head of Brain 2, which is a center specialized in non-invasive neuromodulation. And also Professor Faiz, who is a professor in rehabilitation sciences and also an expert on multiple sclerosis. So I will now leave the next part of the presentation to Gert-Jan Pauwels, who is the head physical therapist here at Trainum.
Thank you, Edward, for the introduction. So my name is Gert-Jan Pauwels. I'm the head physical therapist at Trainum. I started here 5 years ago, as well as Edward. So I will now talk about what the benefits are of the robotics and how we can enhance recoveries in patients with neurological disorders and also patients with disorders of consciousness. First of all, these therapies are all evidence-based, where we can rehabilitate the upper and the lower extremities. Those results are reproducible, quantifiable, and we use a high intensity and very task-specific treatments. We see in the scientific studies there's a significant reduction in impairment of functions, and these results are long-lasting. They can last over 12 months, a period of 1 year. The therapy can be for all levels of impairments, severity, and types. So we can treat more acute patients, but also more chronic patients. What's very important about robotics is the high motivational factor, as Edward also explained in the previous slides. And we achieve our recoveries through neuroplasticity and the principles of motor learning. Next thing that's a really big benefit for us is that we can efficiently assess, documentate, and report. This also links a bit with the high motivational factor, because we want to involve our patients in their recoveries and show them their assessments and their reports. So as I said before, we use the principles of neuroplasticity. I will not explain all of them to you, but what's very important for us is that we use a task-specific movement and try to make a lot as repetitions as possible. For example, the Locomat system, which is an exoskeleton system, lets the patient walk in as natural walk as possible. We put them in this position and we try to make more than 400, at least 1,000 repetitions. How do we harness this power of neuroplasticity? First of all, it's very important that we use proper rehabilitation. That, as Edward told us before, We set goals, and we measure these goals with our assessments. Also, we need a lot of repetitions. As I said, we use a minimum of 400. 400 is the minimum of repetition necessary to change the brain. With these robotics, we can create in half an hour, more than 1,000 repetitions. This treatment is based on focused learning. So this means that the patient has to do games. It's game-based therapy. So their involvement is as active as possible. The active movements are better than passive ones. And the robots will tell us how active the patient is at that time. Of course, it's a big challenge for us to treat patients with disorder of consciousness and let them walk in a robot or use an arm robot as active as possible. If they have low consciousness or no consciousness at all, this can be very challenging and very hard. But when you can't do more, the passive movements of the device will still help. The other interventions we try to do here is the not invasive neuromodulation, the brain-computer interface, and we work together with a neurologist. So the drug and pharmaceutical aspects is as efficiently as possible. So I will now discuss patient case. The first patient case I will discuss is a patient with locked-in syndrome, who is here at our center since the beginning, since 2017. He's a 28-year-old male who suffered a traumatic brain injury due to a car accident at the age of 17 and was later diagnosed with locked-in syndrome. He has been in a coma for several months and had multiple near-fatal pulmonary infection during those months, but also after that. He was able to understand everything around him, but he was unable to respond and make voluntary movements. The protocol we suggested was a training with our Locomat system, with the exoskeleton system, where we did 2 sessions a week, lasting 30 to 45 minutes of active therapy. During those sessions, we saw there was some, after a while, some voluntary movement was possible, especially in his right hand and arm, and is in some aspect of his legs. After we saw that, we started immediately with the upper body training using several types of robotics. We use an exoskeleton system. We use the more anti-vector-based system, the Emotion from MIT, and we used sensor-based technologies from Tyro Motion. We wanted to engage him as actively as possible. The goals he achieved in this period of time was that he was able to independently drive his electric wheelchair with his right hand and arm. And we saw that he was not being hospitalized since the start at Trainem, so now more than 4 years. The weight and walking parameters of the robotic gait training also has improved. His current goal now is to commute to and from Trainem independently. So basically, he had functional effects, but those effects were a bit smaller, but makes a big difference to him because he can now go from one top point to another one independently. The secondary effects were way bigger in his case. He was generally stronger. There was an improvement in brain activity seen. He was less susceptible to pulmonary infections. He's more energetic. He has a better blood flow, making him less vulnerable to decubitus wounds. And we prevent partially osteoporosis. In this slide, you will see an overview of the first couple of sessions he did here at the center in the Locomat. So we've seen that there has been a change in distance and speed. So he was able to put more loads onto his legs and to hold on for a longer period of time. In these graphs, you will see the difference from the parameters from the robots. So as I said, he was able to put more weight on his legs, walk a longer period of time with a higher speed as well. What's very interesting to see is that in the next slide, you see an overview of all the times he has been to the hospital in the past years, in the years before TrainM, and all the times an ambulance has come to his home to take him to the hospital in a bigger emergency. From the time he started at TrainM, there has been no hospitalizations. His immune system was better. There were no severe pulmonary infections. The second case I'm discussing is a traumatic brain injury case. This person has no disorder of consciousness, but I will compare some results with the last patient as well. So this was a male, 25 years old, who had an accident at the age of 17. His protocol basically was the same as the previous patients, but we added an anti-vector system, the GEO system, as walking rehabilitation. The GEO system is only possible when there's a minimum of function in walking. So the goals he achieved was he was able to lift his arm for the first time since the accident and can now independently drive a forklift again. He also can walk independently without any assistive devices. When we see his results, you see there are some functional tests included here, like the trunk impairment scale, box and blocks test, and 9-peg test, where we see an improvement in trunk stability, trunk control, in fine and gross motricity. We also see an overview of the parameters of the locomat. Just to show you, in patients with a disorder of consciousness, it's more difficult to assess functional improvements because the patient cannot always perform the functional tests. The further challenges we face in treating patients with these kind of disorders are that when they are less conscious, it's more difficult to engage them in our therapies. We want a lot of engagement and we want to increase our patient involvement. Secondly, the patient cannot indicate if the therapy is too tiring for them, making it a challenge for us to determine proper therapy loads. In the future, it can be helpful if we combine several technologies to engage those low consciousness patients furthermore. For example, hybrid systems that work with a locomat system and with the brain-computer interface. So I would like to thank you all for listening to us, and I hope you learned something from it. Thank you.
好，谢谢。前面两位讲者是来自比利时安特卫普的这个神经康复机构，跟大家分享的这个 DOC 神经康复门诊的挑战，介绍他们这个 TrainM 这个集中项目在这个神经功能障碍的病人当中治疗的一些经验跟体会。一位是这个TrainM 的联合创始人、首席执行官，另外一位是首席物理治疗师。当然，在他们的这个报告当中呢，有一些个比较时髦的名词儿，比如说 Neurogaming， 我还搞不清楚。我刚才特意网上查了一下 ，Neurogaming 是一个游戏公司的名字，所以这个游戏是跟这个虚拟现实很多结合起来的。那包括其他的脑机接口呀，包括这个机器人技术，所以还是非常有特色的。但是在他们的介绍当中呢，也强调了他们实际上并没有介入到非常这个严重的意识障碍的病人。介绍了一个 TBI 病人，他是肢体功能障碍的；另外一个是 Lock-in Syndrome 病人，没有这种 MCS 啊这些病人。最后当然他们也提出来要为更多的意识障碍的病人制定一些个个体化的，包括定制的一些个治疗康复的方案。相信这些工作对于我们国内的同道，也是非常有启发帮助的。那么我们的会议到现在呢，已经接近于尾声了。那么，这个来自全国不同单位的神经内外科医生、神经重症医生、神经影像医生，包括神经康复医生， 和很多神经生物学的基础研究工作者都参加咱们这次会议。那么下面我们最后一位讲者呢，也是今天咱们会议的这个刚刚上午开始的时候的做报告的专家 Steve Lawrence。那么大家都很熟悉了，再介绍一下 Steve Lawrence 是国际意识研究协会的主席，也是国际意识障碍研究的顶级权威，是欧洲 DOC 的判定的负责人。那么他的目前主要的工作呢，是在比利时利尔大学昏迷科学团队和 Giga 意识研究组负责这样一个工作。做了很多欧盟的计划，包括这个很多的研究项目，获得了这个比利时的最高的科学奖，就是法郎基奖，这是2017年。Steve Lawrence 是在国内大家做意识障碍的研究人员耳熟能详的名字，也多次到中国来访问讲学，对中国的这个神经损伤、意识障碍的恢复工作给予了很大的推进。那么今天我们整个论坛的最后一位讲者呢，我们把这位置留给 Steve Lawrence， 他要给我们就 Translating Neuroscience to Better Clinical Care in Brain Injury 这个题目给大家做精彩的报告。好，大家欢迎。
Thank you. I believe we had a great day with top speakers. We had Professor Hemphill talking about the coma and the Cure Coma campaign. Adrian Owen on advanced fMRI, help him as in prognosis. Christoph Güger on the newest possibilities with brain-computer interfaces. Olivia Gossery, co-director of the Coma Science Group, together with Aurore Thibault on the different therapeutic options, as did Nicholas Schiff, expert, world leader in deep brain stimulation, but also with Trainem, the outpatient rehab center in Antwerp, one of the most impressive possibilities in terms of robotics, and our friends in Israel from Neurosteer showing us some recent wearable portable EEG devices. So thanks again to all of you, but especially to Professor Hai Bodin. With the team of the Hangzhou Consciousness Institute, and I should also thank the Mind Care Foundation. Really, this, to me, incredible meeting has been a success. And today for me is a special day. It is an anniversary of 15 years of friendship and collaboration with Haibo. You see here some older pictures with Nicholas Schiff and Adrian Owen, already with Haibo and myself in New York at the Academy of Medicine in 2007. The Royal State visits in Shanghai 2015, the International Expo 2010 Shanghai, and then 2018, a wonderful meeting where I feel, of course, with COVID, very sorry that it is not possible to be there now physically with you. And I look forward to be able to visit China, Hangzhou and Shanghai again, hopefully in 2021. So today, with this impressive list of speakers, clearly we've seen how the current challenges to translate this neuroscience, this knowledge, into better clinical care after brain injury. And I think that we have repeatedly heard and seen evidence that the old simplistic view that patients who survive coma but can't communicate are kind of hopeless is not necessarily true. And sometimes we are afraid to give families false hopes, but maybe we as a community have committed the error of having false despair. And so this is why I think it's very important, also in terms of the language we use, not to keep referring to patients after coma who have the eyes open but can't communicate as vegetative. Persistent vegetative state, to me, is a term that should be abandoned and replaced by unresponsive wakefulness, because that is way more respectful. We will not compare patients with vegetables. And we should no longer think that there is nothing we can do for none of these patients, because there is something we call brain plasticity. And modern neurotechnology and the different brain scans and scientific results that we have seen today illustrate that there is the possibility for some of these patients to regain a life worth living. And that is what we have seen in Belgium with the Coma Science Group and the teams of Olivia Gossery, Aurore Thibault, myself. Over 900 patients we have assessed. And the challenge now is to, again, translate. We have together over 500 patients, 500 scientific papers, many, many books, but now we need to translate that to better clinical care. And that needs to happen in our hospitals. So it is wonderful now to share the expertise within international networks between Europe, Belgium, and China. And I'm now also happy to announce the collaboration with my team in Canada. So truly, we can also, in collaboration with industrial partners, and I should thank there the Chindi initiative, really optimizing the care for patients and their families after coma. And this, of course, happens in international networks where we do know, as you can read here, that patients who are unresponsive, even chronic unresponsive wakefulness, or minimally conscious STAR, which is comparable to cognitive motor dissociation, or locked-in syndrome, as we have heard today, can benefit from new technologies, improving diagnosis, prognosis, but also, and importantly, therapy and rehabilitation. And this is one example here where the combined information from positron emission tomography, and that's what you see on the top row, with the MRI structural information. And here is one example of diffusion imaging showing white matter structural connectivity. And then the functional tests, such as active fMRI paradigms, are already being performed by our friends and colleagues led by Professor Haibodi at Hangzhou and his Consciousness Institute. So we have here a Chinese patient studied on your MRI and your glucose PET scan, with sharing of the expertise, introducing these patients in our huge databases and permitting computers and artificial intelligence to, again, optimize the clinical care and give us probabilities of whether or not this patient is going to recover and whether or not she or he will benefit from the different therapeutic possibilities. And so we heard today that there are a number, both pharmacological, amantadine, zolpidem, electrical stimulation, invasive and the pioneering work of Nicholas Schiff, non-invasive, the expertise of Aurore Thibault, vagal nerve stimulation, but also music stimulation. So we are in a different world today, really able to improve the outcome of coma survivors, both traumatic, hemorrhagic, and even anoxic cases. So wonderful to do this together with you, not only in Hangzhou or Shanghai, but to really offer this through the possibilities that now exist to a much wider community with more and more hospitals participating and sharing the data, sharing the expertise. So this actually is exactly why Chindi can be helpful here. It is improving the pathway of care all the way from intensive care, hospital stay, rehabilitation, and the return back home, if possible, return to work, return to school. But in many cases, that is not realistic, and we will need to optimize the multidisciplinary care and integrate the new technologies that we have just discussed. And it is truly wonderful, and I think we should really have a big thank you for the impressive work of the International Volunteer Group, because they are very close to the patients, their families, and together, both in China, in Europe, and in North America, we try to improve their outcome. There is one topic we didn't touch upon today, and I want to use the opportunity to very briefly invite each and every one of you who are confronted with coma survivors to maybe pay a little bit more attention to near-death experiences. So this is a different topic, but I do believe it is a fascinating one. As you know, some patients survived their coma. We thought that they were just unconscious and had no thought whatsoever during this period, and yet they would tell us they had this incredible experience. They felt most of the time very, very good. They had out-of-body experiences in about 80% of the cases, seeing this light tunnel, which is a big, big challenge for science and medicine to actually explain and understand. And this is why the team of Charlotte Martial in Belgium is really launching a number of scientific projects. She has written a recent review in Trends in Cognitive Sciences, and I would all invite you to consider joining the effort. We need more testimonies about near-death experiences in China to better understand possible cultural differences. So please write down the email NDE for near-death experience at uliege.be. We would be very happy to share our protocols with you and just ask coma survivors who had a memory to go into the database. Well, we come to the end of a quite long but fascinating scientific journey. I think the different speakers have highlighted how new technology, and especially neuroimaging, is helping us to have better understanding of the physiopathology after coma and the impairment of these awareness networks, both external or sensory awareness with the areas on both hemispheres, frontoparietal associative areas, and then this midline internal awareness network that we try by all possible means to stimulate to get back to normal through rehabilitation. And we had some examples of robotics exploiting technology, including brain-computer interfaces and advanced EEG monitoring, but also with new drug development and electrical stimulation, both invasive and non-invasive. So that's what we all try to do. It helps us to understand the biggest mystery of all, and that is human conscious awareness. We currently see as an emergent property of the collective thalamo-frontoparietal global workspace dynamics, where we can use information integration theory to help make sense of the data and translate that to tools that reduce the diagnostic uncertainty. And if we don't do it, we will have about 40% of misdiagnosis potentially. To reduce the prognostic uncertainty, and as Haibo and his team have shown, for example, with the own name paradigm, fMRI can clearly have a role there, as the other techniques we heard, such as EEG. And then, of course, to really improve the clinical care, offering these patients a better quality of life. And that brings a number of ethical challenges. And also with Haibo's team, we've been looking at that and publishing that. But so the old view that you had these boxes, coma, vegetative state, which is the term we should avoid, it's unresponsive wakefulness. This is challenged by the definition of minimally conscious state, minus, plus, and we have technology that not only helps us to show signs of response to command, but also offers them a communication and improves, as we have seen, their therapeutic options. So this is really what it's all about. It's taking care of the brain through optimized assessment, going to optimized care, using the best possible state-of-the-art technology with neuroimaging, electrophysiology, and new possibilities to stimulate the brain and improve its capacity for plasticity. Thank you so much again, the wonderful team in China who made this possible. Also thanks to the National Natural Science Foundation of China and the grant we received together with Professor Haibo Di at Hangzhou Normal University and the Consciousness Institute, all the partners, all the hospitals in and around Shanghai, permitting us to do what I think is tremendously important, offering patients who survive their coma a life worth living. Thanks also to the Mind Care Foundation for helping us to setting all of this up. It is virtual. I look forward to see you soon and to enjoy drinking some Chinese tea and discuss the future. Don't hesitate to contact us, coma@uliege.be. Xie, take care and see you soon.
好的，Lawrence 医生已经在线上了。Dr. Lawrence